We'll essentially talk about spinopelvic injuries. And so with these, I'm talking about injuries that really disrupt the ability to transmit load from the spine down to the lower extremities. And so the spine, the sacrum acts as a keystone. It transmits load through the SI joints down to the ilium to allow for weight bearing in the bilateral lower extremities. The issue with these patterns is they just come in, there's just such a wide spectrum of injuries. And so you have those that extend directly into the lumbosacral junction, those injuries that affect the superior articular facet, which disrupt the articulation in the lower lumbar spine. And then just our posterior pelvic ring injuries, which, the majority, all of which have a vertical component, do disrupt the ability to transmit load to the injured extremity. And then for our spine, what we generally consider our spinal pelvic injuries are those injuries in which the spine is completely disconnected from the bilateral lower extremities, such as those described here. So our objectives, we'll keep them brief. So the goal is to understand the salient clinical features of these injuries, what's important, what's not important, and to discuss the factors that guide optimal treatment. And the third thing that we threw in here is just understanding the potential benefits of spinal pelvic fixation when it may offer some added benefit in addition to our standard iliosacral screws. And so because these injuries were so varied, there have been a number of different classifications over time. The Dennis classification, the Isler, Roy Camille. Fortunately, all of these have really been combined together in a joint effort between AO trauma and AO spine to create the AO spine sacral classification, which is a pretty unifying classification system that I think will make our future research studies and outcome-based studies a little bit more uniform. But they're worth going and talking about. So the Dennis classification really, the main thing that I was trying to predict was neurologic injury based on how medial the injury went. And so looking at these patterns, you can imagine that the transverse zone 3 fractures, the ones that cut through the sacral canal, are going to be the ones with the highest neurologic injury rates. In terms of the vertically oriented patterns, our zone 2s, our transforaminals, have the next highest rate, usually multiple nerve roots, and then our zone 1s usually present as a monoradiculopathy of L5 typically. And our longitudinal zone 3s, those actually have an incredibly low rate of neurologic injury, less than 1%. And that's why we differentiate them from the ones with the transverse component. This Isler classification, it looks like it's describing the same thing, but the outcome here that is being looked at is lumbosacral stability and really what's happening with the superior articular facet. This is something that is easy to overlook because you just see a comminuted pattern, but if that superior articular facet of S1 is displaced, that patient is going to have consequences long-term, and it may be worth considering a fusion earlier. And then we have our descriptive classification for our transverse fractures, for the fractures that have a transverse component. This was sort of further described by Roy Camille in the subsequent classifications based on how much kyphosis there is, how much translation. This just has implications for the risk of neurologic injury, as well as what you need to do in order to get them reduced. And so you can imagine if a fracture like the young man shown here, this fracture has sort of occluded the sacral canal and puts the patient at risk for developing an acute cauda equina. Which is different than the usual nerve root injuries that we see, like an L5 nerve root palsy in the setting of pelvic injuries. Sacral kyphosis, it's something, the sagittal plane alignment is something that's gained a lot of traction in sort of the spine world. But to sort of simplify it here, if this patient has acutely changed their pelvic incidence by about 40 degrees, in order to keep their head above their hips, now their lumbar spine is going to have to hyperextend by the same amount. And that's, if it heals in this position, that they're going to have to do that forever. Which over the long term leads to poor functional outcomes, fatigue, and the need for subsequent reconstructive surgeries, which are pretty invasive. So if we can address this earlier on, it's better. So the question is sort of, when do you call your spine colleagues for these injuries? I would say if there's a neurologic deficit that's beyond a simple monoradiculopathy or lumbosacral plexus, if you're concerned at all about an acute cauda equina, especially for the transverse patterns, we need to get involved. Because that patient may need an urgent decompression. You can't wait more than 24 or 48 hours, otherwise the bowel and bladder symptoms become permanent. If there's significant sacral kyphosis, it's worth a discussion to figure out how much we're going to correct. If there's a displaced facet fracture. But what we find that we're being called most often for is just providing supplemental fixation to enable earlier weight bearing after just standard pelvic ring fixation. Our operative treatments, the mainstay of treatments are iliosacral screw fixation for the posterior sacrum. The other option is posterior lumbopelvic, so we'll dive into sort of the pluses and minuses of both. Iliosacral screw fixation, it's safe in well-trained hands. The complication profile is pretty low. It's minimally invasive. You could do it in either the prone or supine position. For our vertically oriented fractures, you could generate fracture compression by either lagging by technique or lagging by design perpendicular to the fracture line. But it is just a lag screw, as opposed to a lot of other places where we neutralize our lag screws. A lot of times we don't have that effect here. And so it's pretty poor at resisting shear forces because this is how the hemipelvis wants to displace. And you also need pretty good floor images, which is sometimes limited if there's a lot of bowel gas or obesity. For spinal pelvic fixation, it can be minimally invasive now with the technology that we now have. If the pelvis is reduced, you could easily put this in percutaneous. The main advantage, though, is the biomechanical advantages where, in terms of hemipelvis flexion extension, and so with these constructs, you can allow immediate weight bearing as long as the patient doesn't have any other injuries on that side that limit your weight bearing, such as like a plateau injury or anything of that sort. This is the older generation of percutaneous tulips. The newer stuff is probably like 25% smaller, so you can even get, do it through smaller incisions. The cons is if you do require an open approach, it is pretty invasive. There's a high rate of degloving injuries underneath these injuries, and if you do extend up to L5 or L4, you do limit lumbar motion. You need to be careful with how you put in the hardware. The tulips all need to be underneath the fascia. A lot of these patients will lose 20 or 30 pounds in the next 6 months, and so what may not be symptomatic initially may be symptomatic in the short to midterm. And then this, of course, necessitates a prone position. So. It's hard, sometimes you need to wait for things to clear up. The patient's abdomen, the fascia needs to be closed and that sort of thing. And then we can combine our techniques. And so this triangular osteosynthesis, this is essentially just a lag neutralization construct, right? So just going back to our AO principles. And so our goals of treatment, bony union at the fracture site in physiologic alignment. We want to optimize the potential recovery of neurologic deficits by decompressing any ongoing compression and to minimize the potential complications associated with prolonged recumbency. So how do we choose a fixation strategy? There's sort of 5 things that we consider. The first is if there's ongoing neurologic compression, then the decompression is needed. The next question is how we're going to reduce the fracture. Similar to everything else, we start with the least invasive things and see if we could reduce it percutaneous, and if we can't, then we go open. So for our non-displaced fragility fractures that have functionally limiting pain, these can be treated in situ with iliosacral screws, whereas something like this might require a lot more in terms of percutaneous fixation or opening it up if you need to. And so this patient with an H-type sacral kyphosis, he was 24 years old, a paraglider, and so we opened them up, put in shank pins into S1, put in shank pins down into the ilium, and the goal here is to use these pins to try to distract and get extension. In this patient, it was a high energy mechanism. That didn't suffice, and so we ended up sticking a COP to Kapanji this over, and you can see the COB retractor there. That involves doing a sacral laminectomy, and doing that, you could get a pretty good reduction, although it takes quite a bit of work. And that's the final construct there. Well, this is something that's to overlook, but if you could just look at the amount of compensatory lumbar lordosis pre-reduction and post-reduction, and that's something that is, plays into the long-term outcome. And again, the fusion is, we only fuse if that facet is displaced. Otherwise, you can see if it heals and if they develop any facetogenic pain. In terms of instrumentation, like how we instrument, whether iliosacral screws or the lumbopelvic fixation, is just a function of the bony quarters that you have available and how much you want them to, how much you're comfortable letting the construct load afterwards. And regardless of how you instrument, you have the choice of doing either percutaneous or open. So in general, for our spinal pelvic dissociations, they're generally treated, our minimally displaced fractures are generally treated with transiliac, transsacral screws, especially in the geriatric population. You want to make sure that those screws, capture the proximal segment. And then our displaced fractures are generally treated with lumbo-pelvic fixation. They may require open or percutaneous. Although we are able to do, with newer techniques, do a lot more of this percutaneously. So those were screws, shank spins going down. Did this case with my colleague, Dr. Gendelberg, where shank spins down into the S1 pedicles, into the ilium, putting an X-fix, getting it reduced. And in someone who's marginally housed and has risk factors, we're able to do this entirely percutaneous. And you put in the transiliac transsacral screw as your provisional reduction. And the last thing I wanted to talk about is just a case for spinal pelvic instrumentation as supplemental fixation. And so this is a 59-year-old female who came in last November after a motorcycle collision. This was an open pelvic ring injury with a huge perineal laceration. This is her in the initial binder, still pretty widely displaced. She went emergently for a washout. And so she has a right APC2, a left APC3. That's the initial CD scan. Initially had a perineal washout, an X-fix, IR embolization subsequently, and then a couple of days later had an anticipatory colostomy to help manage the wounds. She had her spine injury treated by her neurosurgery colleagues. On hospital day 7, they closed her fascia by that point, and so we took her to the OR. She had a colostomy on the APC3 side, so we did what we could with an anterior X-fix to control the back. Got the reduction. It's not perfect, but it's pretty reasonable. And then I had, this was her post-op CT. There's a little bit of extension of the hemipelvis on the left side. But it's certainly better than where she started. And so, this could be her definitive fixation, and with an APC3 on one side and an APC2, not too many people will let her weight bear immediately. And so with this construct, I talked to her, I was like, I'd be comfortable with you, using your right leg, the APC2 side for transfers, but not putting weight on the left. And then I talked to her about, just adding additional fixation. And so we elected to do S1 to ilium. And so we used, and then we tunneled a cross-connector subfascially, posteriorly, and this is what she was left with. This was the incision, so it was a 3.5 incision to tunnel the cross-connector subfascially, and those stab incisions. Those staples are from the neurosurgery case. I don't know why their incision was so long. And then we only went up to S1, and so we did not cross the lumbosacral junction. She does not need a hardware removal afterwards. We let her weight bear as tolerated initially. She was taking some steps at the end of her hospitalization and then AFO. She was ambulating independently with a walker when she came for her suture appointment, and independently without at 6 weeks, which is not terrible for an APC3, APC2. And so our main indications here, our absolute indications for spinal pelvic is the unstable junction, if the pelvic morphology precludes traditional fixation, or if there's hardware in the way, like this axial lift. And our relative indications are, our displaced vertical shear components to neutralize that, and to provide, to allow for immediate weight bearing. And of course, there's no need if a patient has a stable ring injury, or if they can they've been fixed with traditional instrumentation and can weight bear or can tolerate a period of limited weight bearing. Thank you.